well, that was it. Hello, everyone, and welcome to our second session of Leadership Exchange Live, BEEEBAH Edition. I'm so excited. This is going to be such a great conversation. We're here with Marielle Gross, who is a doctor out of Johns Hopkins in the University of Pittsburgh. The affiliations. We've sat down and spoken before, and it was at a time when I did not have the experience that I have now. So I'm really excited for this conversation. Are you able to hear me? Okay, great. So if you don't mind just giving a little bit more of an introduction of who you are, and then we'll jump right into the conversation.
Yeah, sure. I should say I'm joined here with a friend who's gonna bark if we don't have her on camera with us. This is Gertrude, my dog. I'm Marielle Gross. I'm an OBGYN and bioethicist at University of Pittsburgh, UPMC, and Johns Hopkins. And I come to this issue by way of studying structural justice in learning health systems, and really firsthand encounter practicing in Baltimore, running into patients really challenging me the same way that you've challenged your clinicians for evidence-based recommendations about handling breastfeeding in the setting of HIV. And I'm happy to be here and looking forward to our conversation.
I'm so excited. So, as a medical professional who supports women living with HIV to make informed decisions when it comes to how they feed their children, what would you say are some of the providers' biggest concerns about breastfeeding and HIV? And how do you respond to these concerns?
Yeah, we kind of talked about this before. I think, sadly, that most people practicing medicine are, really the expression trying to keep your head above water comes to mind. They're working their butts off trying to do a good job and take good care of people, and the issues on which you can be, you need to be informed at the up to the minute evidence, and in this case, cultural change too, I think, of practice are many. And it's, I just want to sort of start by saying that it's not easy to do a good job in our field. And most people are just, in that setting, following the guidelines that they were taught, which can be hard to know when those individual guidelines, of which there are many, are evolving. And so I think most people coming, at least in the United States, Canada, in Europe, who are practicing today, were trained in an era where we were told, blanket, categorically, no matter what, in the setting of HIV, tell people do not breastfeed. And with different forms of language, but all across the board as a categorically don't do it. And that is, I think, what most people assume is correct and evidence-based. And as you know, in my work, I've explored and challenged that. And I think that when it comes to, people on the ground encountering this issue in real life today, I think that their gut instinct is to react as in, isn't that harmful? Can't that harm a child? And fear about that, and fear about being either implicated as somebody who provided guidance that could lead to the harm of a child, and therefore the harm of their patient, say if their patient is you, and concern about the medical legal risk, and sometimes, unfortunately, in the reverse order. I think that those are the main concerns and sort of reactions that people have when you say, "What about this?" to them, as I've been doing for a few years now.
And I am so grateful for your work. Now, I feel like I have, some input to give that is much different than the first time that we may have, been in the same space. So meeting with you for that first time, that panel that we were on in 2019 at USCA, that was the first time that I ever knew that there was a possibility that women living with HIV could breastfeed. Like I had never heard those two concepts in the same sentence at once. And I'll keep expressing to you how grateful I am for that experience. I'm not sure if you want to get back in, and throw anything at me as we'll be exchanging thoughts here in this conversation, but so grateful for the work because at the beginning it was just a strict no. When I gave birth to Zion back in 2010, excuse me, it was no. Like we didn't even have a conversation about how I would be feeding my child. I birthed them and then we were automatically given formula and that's what I was sent home with. And for so many years, I just felt like I was toxic to him in some type of way, especially being that I was not able to breastfeed.
So can I interrupt you and say that first of all, I've had people tell me to validate the context to which you're explaining. I've had people, back in those days, tell me we cannot even talk about it. We can't even counsel people about it. We just have to, have a straight no policy and inform people, so to speak, of that policy, no further discussion, because of the fear on the part of those providers that even having an informed decision conversation would be perceived as being in favor of or somehow supporting or endorsing, condoning breastfeeding. So that's how severely providers were, certainly back then, and I think to an extent in some areas today, we're really afraid of that, even having that informed discussion, like you said. So it was not just a no, it was like a no, and we don't want to talk about it, which is worse, obviously. And the second thing that you said, I think, which is tremendously powerful and really absolutely critical context for this conversation is, and kind of the rest of the answer to the first question you asked me, is that thought, the terrible thought of you being toxic to your child, and the extent to which, on some level, the policy that we were talking about, was responsible for that thought on your part. And not just that policy, but the surrounding policy and the history of how we treated pregnancy for people living with HIV, right? So it's a terrible thing to say, and it's a huge testament to your courage and to expose that as true, as a true thought that the practice of medicine could lead someone to credibly think was, accurate. And to me, that was really my hook, was like, in getting into this issue, was full of the clinic as signs of breast is best, and the imagery that goes along with that and how powerful that is. And to have our patients in that same environment and sitting there saying, but not for you. For you, that would be bad, because of the underlying moral implication that, that there's a badness or a toxicity in you performing the thing that we're not only say our human body is meant to do, but that we're preaching to everybody else as important. So anyway, I think it's a huge testament to your courage for saying that out loud. But I'm saying that I think that we have a huge responsibility to own up to, which is making you feel that way.
Oh, thank you. I definitely, for so long. And now it's kind of, since I have been breastfeeding now for we're a week shy of 5 months. And to not have transmitted my virus to my child and to have support from providers has been the hardest thing to wrap my mind around now. For it to be something for so long that I felt like I couldn't do. And HIV was the reason why I could not do that. To now have, providers that are listening to my desires and my wants and actually helping me make it through this very tough and sometimes very uncertain experience that I'm going through. It has meant the world, honestly. So, before this, we came up with these questions that we were Yes, back and forth. And I loved your set to me. So are you ready for one?
Yeah, well, I think you're sort of leading us into that first question for you that I had for you, which you started to answer, which is really, what do you know now that you didn't know then that you wish you knew?
Oh, that recommendations aren't like law. I did not know that I could challenge anything that was, said to me inside of my provider's office. I thought that, you know, each of my providers that they knew everything that there was to know about a certain particular topic and that what they said was what I would have to do. I I didn't know that I could open my mouth and maybe question, and it has begun to spread even outside of just pregnancy, breastfeeding, and HIV. It's like this medication I'm on. I can question, whether or not there are other alternatives. I can, question why such and such I'm seeing on my chart when I log in afterwards that I actually have a right in my care. And I didn't know that then. And I kind of had an example of that when I first got pregnant this time, with me going into my provider's office and she telling me that I would not be able to breastfeed. And that had to end like our professional relationship right then, because she wasn't willing to support, or listen to anything that I desired. And I realized that, oh, I can, go over to a different provider that will listen and I can get set up with a different team. If I would have known that back then, maybe I would have fought a little harder and not, and maybe the outcome wouldn't have been the same, but I didn't feel like I had a voice. I did not feel like I had a voice. Um, I'm grateful this time. I'm grateful for providers that are willing to listen, are willing to even entertain something that may not be, immediate to them, something that they may not have ever heard of, or a foreign concept. I'm so grateful that we are able to sit down and have conversations like this. This is life changing. And I know it's not just for me. I know this for so many other women, so many other parents out there living with HIV. So thank you again.
I think you have like such a way with words. It's funny, the word your words really just like last time they resonated and bounced around in my head for a long time. So thank you for that. And I think you highlighted yet another, so two really important things from your last comments. One of them is really, well, I'll start with the negative side of it, which is that recommendations are not law, but in this case of this subject matter, they have been enforced by laws, both formally and in hospital policies. So both recommendations absolutely are not law, and it's such an important. Just that statement alone is should be like on the website, right? As just because of it gestures towards um, the critical importance of patients as partners in their care, right? Because I mean, taking the consideration of what I kind of started with saying, like providers are trying to do a good, 99% of the time they're working their tails off to just provide with the limited resources that they have the highest quality care that they can. But they're not a one woman or one man or one person field of medicine unto themselves, and they rely on patients to educate them about things that matter to them, that as the field of science moves past where it was when they were trained. Otherwise, they're just running that programming that they were taught, assuming that that was evidence-based and that it continues to be. But if it's not, we need patients to be like, hey, have you seen this? You know, this is different now. How could they possibly stay on top of all these things without help? And patients are one of the most important sources of that. And they tell us the areas that we need to educate ourselves on, in addition to being the most important, I think, source of that education itself. Um, so super important to, and really that's where the positive side of it is, that you're absolutely, I think, hitting on why I became so much more passionate about this space over time is by seeing how, just like you're saying, it was not just about HIV and breastfeeding. It was about empowerment writ large. Like the fact that you're taking it with you to say, you know what, also, by the way, about this medicine, or can I do twice daily dosing? Does it have to be once a day? Or, what about this? Or really giving you the authority and the voice over your own body, over your own care as an expert. And what I say to patients, maybe it sounds, I'm like, the most about you. I might know more about your uterus or, your, reproductive system or labor and delivery, but you know the most about you. And so we can't have the best possible outcome is only enabled by collaboration of two experts.
Oh, that is so deep. Like, just, can you hear me? I look a little frozen.
Yeah.
Okay. Just those power dynamics, and I was just reading about some of this in the WRI report that was just released by the Well Project. Those power dynamics that I didn't have a word to explain what they were before. I didn't know what it was. I just knew that I felt, I want to say less than, and in some instances maybe less than, but didn't feel like I was on the same level with a provider when I walked in. So I did not feel that I could say anything that it would be responded to. I felt like, my words didn't mean as much as theirs. So definitely talking about those, sorry, the barking dog, those power dynamics that I would love to be able to help, other women, other people to be able to know that, yes, you are an expert in your care. I love your words. You are. And while that's true, you might know a little bit more about what's going on inside of my body, but I'm the one that lives this life with this body, and I appreciate being listened to. Actually, it's imperative, because if I'm not taking part in my care, then it means that I'm just doing what you say. And that isn't always the best thing for all of us. So,
Or not
yay.
doing what I say, or not doing, right? Like, just whether it's, it becomes more dismissible guidance, even if it's well intended, and even if it would be better if you did follow it, if you don't engage with it and contextualize it, like you're saying. And I think so, not to leave this issue without really, when I talk to my colleagues about this issue, the power asymmetry in this area, and it's in particular, I don't know if you could hear, I live on a train track here. There's like a train blaring in the background. It's great. It's like in My Cousin Vinny. But I talk to them about the power asymmetry, and even just from the beginning of getting involved with this as a resident, and being like, I can't believe, like, we just la-di-da tell people don't do something. Like, you can't just like la-di-da tell someone don't breastfeed, don't have sex, don't do these things that are like we're physically designed to do, and how much we better be prepared to show how it's better for that person for them to not do that, or better for others, or whatever the case may be, that we have to have really good reasons to tell people not to do what their natural instincts are telling them, because of how harmful that can be, both just psychologically even. And so I didn't find that evidence for evidence to justify such a strong position from the medical field when it comes to breastfeeding and HIV. And I think that the broader context in terms of the legitimate fear of jeopardizing custody of your child, or even just the fear of being ridiculed and forced to defend your custody of your child while you're recovering postpartum in the hospital, takes that power asymmetry like this and just exaggerates it tremendously. And so really attending to that and understanding how that disinvites conversations, and how that not even with the outcome that we intend, it disinvites conversations, and it invites people to go do what they're going to do once they are no longer faced with us. That's not really consistent with the goal either. But it is a really important thread that I think we really must not let go of, and that threat is real. And it's manifested in all sorts of ways today. And it's experienced differently by different people in different localities who have different levels of empowerment.
So I always think of this. I pride myself on being, very open with my provider. Even things that I probably shouldn't be engaging in, I'll share this information because I need you to treat me. With my mental health services, we come together and we do my treatment plan together. Like, are these the things that you want to work on? I agree. We sign off. Cool. But then coming over, to my medical care, I felt like at one point that if I wanted to breastfeed and I was actually advised to, that I would have to keep that secret, or it would be better for me to keep that secret. And to me, that kind of went against those things that, like, who I am as a person. I need for you to know all of the details so that you can treat me appropriately. I don't think that doing it in secret, I didn't want to do that. Because look, the baby needs Marvelows done. I need to make sure that I'm well. You need to know everything that's going on. And that criminalization piece is so hurtful. I have, been a law abiding citizen thus far. And my parenting is what have put me up to be a criminal, because I wanted to feed my child. Let's not forget that I've been raising this other child for 10, 11 years at this point. But because I wanted to feed my child from my body, now this would put me at risk of, CPS coming to my house, which is, coming from where I come from, is one of the biggest concerns anyway. Like, you don't want those folks to show up at your door. Someone not from the neighborhood comes up with a briefcase, you automatically assume that that's who it is. And I have been able to avoid that for so long. But now, because I wanted to feed my child from my body, this has now become a whole situation. And I make the correlation between, now I got to make sure I always have vegetables in the freezer, and I always have a certain amount of food, in my house. And my house is always presentable just in case somebody is to pop up, because I have decided to breastfeed my child. And it's so not fair, because postpartum, you're already going through so much, for any parent. And to have that added layer of fear, oh my God, it's so heavy. So heavy. So that's why I highly suggest that people find providers that will support them. That has not been our story so far, which I'm so grateful for. But I'm afraid that if I have stayed with my previous provider, that wouldn't have been the same story. So, oh God, we've already talked about USCA 2019, which was the day that changed my life. I heard this was the first time that I heard a provider speak on the benefits of breastfeeding, particularly for Black women, regardless of the parent's HIV status. This was life changing. Can you speak to what some of those benefits are?
Yeah, I mean, and this is true for my practice in general. I think when we talk about breast is best, it's a very baby centric conversation. And in reality, the evidence shows that the differences in high income settings, anyway, this is a critical difference between high and low income settings, actually, where the health benefits of breastfeeding statistically are documented to be even greater for morbidity and mortality. So living longer and healthier for the people who could breastfeed than even their children. Not that they don't have those benefits too, and not that they're not significant, they really are. But when I'm counseling people, say in the hospital, who are in between, or who are, struggling in their initial part, and trying to give them that, added motivation to stick with their plan when you're faced with all of the reasons why people make it easy to deviate from that. in that setting. And I really talk about the health benefits that we've shown to women. And those benefits really fall into three major categories. One is the benefits related to metabolic syndrome and cardiovascular disease. So everything from high blood pressure, heart attacks, strokes, diabetes, these sort of major cardiovascular morbidity and mortality sources, like in fact, the leading sources of morbidity and mortality for women overall in the U.S. Those are all substantially decreased with any amount of breastfeeding in a dose-response relationship, which means the longer you do it, the better, but doing any has a significant decrease in the risk. And a lot of that has to do with the extent to which, although again, this is not totally well understood, but a lot of it has to do with the extent to which pregnancy mimics a diabetic state by, and why people get prediabetes or pregnancy-related diabetes because of the increase in sugar available in the bloodstream and its sort of impact down the road. Increase in blood pressure related to, preeclampsia and other disorders of blood pressure in pregnancy when those things stick around. And being able to achieve a healthier metabolic state through breastfeeding is one of the ways that you can reduce your risk that is increased by having those kinds of conditions in pregnancy. So all of that, those are things, major morbidity and mortality. Heart attack causes death, right? The other major category is also life-threatening things related to cancers of the reproductive system. We don't totally know why. And there's some theory, but rates of breast cancer, rates of ovarian cancer, rates of uterine cancer are all significantly higher in people who never breastfeed. Even if you compare people who did have, there's also significantly higher sometimes if you do or don't get pregnant ever. But if you get pregnant and you breastfeed, you're much lower risk for each of those kinds of cancer, uterine cancer being the most sort of common female reproductive tract cancer, breast cancer being the most common cancer diagnosed worldwide, substantially lower risk for people who breastfeed. There's a dose response that's not as strong in that area, meaning yes or no ever is the most important thing. And importantly, I think, I'll give the last category has to do with the fact that breastfeeding, especially breastfeeding exclusively, meaning doing nothing else, decreases the chance of you having another pregnancy really short on the heels of the last one. And it's those second short pregnancies that are really risky in terms of from maternal and neonatal, perinatal death, miscarriage, uterine rupture, catastrophic bleeding, abnormal placentation, the kinds of things that really can result in increases in morbidity and mortality surrounding a pregnancy and a labor and delivery. And then stepping back, we can look at each of those three categories and say how actually in the US, and I'm not a super expert on the global data, but in the US, maternal morbidity, mortality, cardiovascular and diabetic complications, and cancer mortality are all substantially higher in Black women. And that's one of the reasons why our society guidelines emphasize the importance of encouraging breastfeeding in BIPOC populations because of the disproportionate degree of risk for the kinds of health things that affect our patients more. And in the meantime, there's about a 20% difference in the rate of breastfeeding between those populations that are most affected by those diseases and those who are not. And that's just upon leaving the hospital. It's about 20% off in terms of the rate of breastfeeding. And so there's something that's not without its substantial reasons, right? But the extent to which a policy could go against that because of the rate of HIV in this country is 20 times higher if you're Black is like why this is such a, I think, unjust policy that doesn't consider its impact on health overall. It's a knee-jerk reaction based on fear, a legitimate fear that has been since colored in by evidence that can, tell us what we should really be afraid of.
That's deep. That is so deep. Yeah. I'm without words after that one.
Well, we were
Um,
talking at the end of your last comment, you were talking about fear. And one of the questions I did have for you, if we want to go back to that, um, is really about people who might be considering breastfeeding but are afraid. And I thought that you could give your advice on how they can navigate that.
so I understand it. If you don't feel like anyone else can relate, there are us out here who can definitely relate. I went back and forth the entire pregnancy. It was like, I really want to breastfeed, but today I don't know about it. Today, okay, I'm gonna do it. Um, and I'm grateful to have been given the space to do that because it wasn't about whether I breastfed or not really. It was just being given the choice to be able to do that, given the space. So my advice for anyone is to start early, start extremely early. Um, Start considering it, start researching, start talking to other people who may have been in that position. Definitely get in with some providers because as I had the support and the research, in my one ear, then I was able to kind of subside on some of those fears. After the first few tests came back negative, then I was like, okay, maybe we can do this. Maybe, we're doing it. But fear is definitely an understandable emotion. I was like, okay, it would be me. I would be the one person who, where a transmission would occur. It would just be me. And then once those tests started coming in negative, I'm like, okay, all right, maybe it's all right. It was definitely a lot of reprogramming in my own mind that had to take place. The support system has to be is at the top of that list. I would not have made it without mine. Please, I don't want anyone to feel like they had to do this alone. Like maybe it's not in your provider's office where you're finding the most support, but there are support groups available. There are, communities such as the Well Projects, full of women who understand, who get it. So definitely find a support group. That helped me a lot to overcome the fear that I've felt, throughout the pregnancy, even up to this moment right now. I still, every now and then, a thought sleeps into my mind and I have to, kind of shoo it away. You are not alone at all. Um, Being a black woman here, in the US and hearing all of the data or, the facts that you're able to give me about our higher increase of certain things and then our rate of HIV being so significantly higher than our counterparts. It makes me feel away. It does make me feel away. But at the intersection of race and HIV, we know that there are health disparities which exist for Black and Indigenous women and other women of color. We also know that Black infants have a higher infant mortality rate than their white counterparts. What do you think it would look like if Black parents living with HIV were given the support and autonomy to make the decision to feed their children in the best way possible for them? What would that look like?
This is where I get back to what you had said before about how the this issue and your process has bled into how you interact with healthcare overall. And to me, what it would look like is like, I don't know if this expression, like a toe in the door towards an open door and equal relationship that we know does not currently exist. And it's a opportunity. We can look at it as one for really, I think, correcting a relationship that between U.S. medicine and Black women in particular has been just fraught with all of the problems that we all now know about, that have been called out. And I think it's important to call things out. And I think that's actually been done for quite some time now. I think Dorothy Roberts really puts it well, that a lot of these disparities, like the ones that we were highlighting, I mean, these are being called out, the 2 to 3 times worse, right? 2 to 3 times more likely to die, 2 to 3 has been called out time and time again. This is a concrete action that takes a step in the opposite direction, I believe, because of its impact on destabilizing an asymmetric power relationship and putting that power in the hand of the person. And that's, I think, true even if people don't decide to breastfeed or not. Being empowered to make that choice about your own life and your own body by your healthcare providers is what gives you that voice. That is what we need to make healthcare safer for Black women and their children overall, right? That's why this is, like, I think, so important, because it goes so far beyond this issue. But it's appropriate that it starts at birth, right? It starts at the beginning of new life. And it is a way of, I think, for both patients and providers to take that step together towards saying, like, we inherited this system that's broken, and this is a move towards repairing it in, like, a really concrete and meaningful way. So I don't know if that answers your question, but that's kind of how I view it. And it's like, it's a step that's, again, it's a small but really meaningful one. Not that small.
Not that small, and definitely meaningful. Oh, this is such a good conversation. Thank you so much again for having it with me. Would you like to go next?
Yes, wait, I have my list here. Hold on. Okay. All right. Well, I only have the language that I have, which was like, give me your real story on this mixed feeding. The truth, when I counsel patients, I say it's almost never, like, almost nobody does 100% of breastfeeding without ever a sip of formula, or 100% of formula without ever, being placed on the breast. It's like not real life to me. And so when I see people struggling, like, with this all or nothingness of just breastfeeding in general, that's how I sort of frame it. But in this space, the dictum among those, it's like we move the needle to this new place, which is that, okay, you could do it if you exclusively breastfeed and all these other boxes are checked. But I guess I'm skeptical, and I don't have children. I've never breastfed myself. I'm skeptical that anybody's actually able to do that in our society, like with the level that we are expecting it. And then of course you have to wean at some point, and how does that go down? So I think we should be challenging this sort of all or nothing dogmatism surrounding mixed feeding, as though it's a, all or nothing kind of thing. I also don't think that I think it's really complicated, because the evidence about mixed feeding in low-income settings is literally contaminated by the fact that there's not clean water in those settings, that the reasons for mixed feeding in those settings are different. It's not because it's their society or cultural things. It's like the person wanted to breastfeed, and then they were unable to for some reason that's outside of their control, or they wanted to use formula and then the formula supply went away, and so they're trying to breastfeed. So these are really adverse conditions in which mixed feeding occurred in the studies that we cite as saying why you shouldn't mixed feed. And in fact, the WHO changed their guideline. I'm just giving like more background to the question. Like, the WHO actually changed their guideline. It used to say, that it was better to do exclusive breastfeeding and then exclusive formula, and then mixed feeding was the third option in terms of the outcomes for the babies. But the current guidelines are not that. The current guidelines are breastfeed as much as you can and use safe alternatives when necessary. And that it's not an all or nothing. And yet we kind of stop short of that in the majority of our discourse. So what's the real story from your perspective?
From my perspective, exclusively breastfeeding has been one of the hardest things I have ever done in my life. I was talking about this a couple weeks ago is, oh my God, it would be so much easier if I was able to supplement at some point with some formula. Like, it would have made some nights easier. I would have saved a couple of tears. I have been in fear at least a couple of nights that the baby has eaten all day, and now here we are in the evening time, and I feel like my breasts are done. There's no more milk, at least not enough to give her a whole feeding right now. And oh my God, my breastfeeding journey may be over because I need to open a can of milk because this baby needs to eat. And how, if I was not living with HIV, that this would, I would be able to give this baby some formula. And then, the pressure from those around me, um, they're watching me struggle for every feeding and having to stop, everything that I'm doing right then. And we don't have the option to formula feed, and they don't quite understand it. So once again, having to explain how HIV has affected how we are feeding this child today. In my culture, or at least, in my environment, she's 4, almost 5 months now. We would have introduced something, some form of, the baby grabbing food out of your hand or whatever it was. But it's like, no, don't do that, because then that'll increase the risk of her getting HIV or something. Because I'm still not too clear on it myself. That is one of those things that I've taken from providers, that mixed feeding is not recommended. So I'm not going to do it because I'm in a very vulnerable position right now. Don't know what I'm doing. I'm expecting, guidance, and they said no mixed feeding, so that's what I'm not going to do. But hopefully, we're able to get some more research or understanding around that soon, because this is hard. In 6 months, like I said, we're 1 week shy of 5 months. I can't believe it myself, that we've made it, and it's been nothing but breast milk. It's tough. It's so tough. Sometimes I just want to give up, throw everything away, where that might not have been the case. Or I know it wouldn't have been the case if I were not living with HIV. It's definitely difficult.
Well, I think it's like, in that I see that again, this is one of those things I see it just in regular situations, right? Without the HIV complication, people are like sort of have this all or nothing. And I think you're an outlier in that you didn't let it deter you and you've been really dogmatic about it. But, life doesn't lend itself to such staunch dogmatism, right? Like real life is like all of the contingencies of real life, and to like throw the baby out with the bathwater, so to speak, because of one sip of formula, to me strikes me as a guideline that is that may not necessarily reflect the genuine evidence basis. And even again, not that we can't understand where the guideline comes from, not that there's not evidence that in certain circumstances mixed feeding was more dangerous than formula feeding exclusively. Again, not in circumstances that you're in, right? And not in circumstances where you're on the medications. I don't know if your child is taking medication or not. I mean, in those circumstances, it's like, I don't know, but the fears are profound, and it just like it's almost like the next hurdle, I think. You know, not again. We preach exclusive breastfeeding is better as a way of breastfeeding, period. Also, but it just, in terms of it being like exclusive breastfeeding the way that you mean it, as opposed to when you go out in the world and people say, oh yeah, I exclusively breastfed my child for a year. Like, do you think that person never gave their kid a simple formula? Please. Like, ever, never? Like that one night that blah, blah, blah. Like, of course not. But it's a more holistic exclusive breastfeeding. And I think a little bit more holisticness, like a little bit more like, would be great. And so my next question, I guess, is that, one of the challenges here is that we're doing all this stuff. How do we prove it? How do we get the evidence of like what you're going through in our setting, and how do we use that evidence to empower both yourself and others in the future? And so one of the questions I really have, and I know you're like, this is kind of out there, I'm like, well, is there an app for that?
I haven't heard of an app. I mean, it sounds like an interesting concept. I would, I mean, that would have been so helpful right now. Um, oh my gosh, that would have been so helpful. And this whole mixed feeding thing, like I'm thinking if I could have just had one thing of formula. My dad was over here one night and the baby wanted something to eat, but I was doing something else and she had just eaten. And I said, there's no more milk. He said, well, where you get formula from? Where I could go buy the baby some milk? I'm like, Daddy, I'm sorry. We can't do that. Like, we just, I'm not able to do that because of HIV. And definitely, when I heard exclusively breastfeeding for 6 months, I didn't think that it would be as hard as what I've proven to myself that it is. And I want to pose that question back to you. Like, how can we get the proof, or the research? Because I felt like, okay, here I am coming to y'all on breastfeeding. Here you go. Here goes a case study. Can y'all do some research? Here's other, parents over here who are doing it too. We're willing to be, study subjects or whatever you would call it in that case. Like, we're willing, but it doesn't seem to be so easy. I would love for someone to use, my case as an opportunity to see that, maybe we can change, or, looking at cases of other women that I know, like a Heather, or, other women that I know in the community. We are out here. So please do the research, because I know that it will help so many people coming behind us. I don't know how do we get that research done, Marielle? How do we
Well,
go
I
for
see,
it?
that's the thing. I think the thing is, you're doing it. We're just not aggregating it and capturing it to then be leveraged in your favor. And I guess this is a question for the community. I mean, people are recording all of their, I'm sure there's apps out there for breastfeeding and all the, I know that I've seen different ones. I mean, there's just like, there's apps for tracking your period and all these different things. And, my real opinion on a lot of that is that it's taking our intimate data and information that's private, and it's selling it or using it for, purposes that may or may not serve your interests at the end of the day. And yet, this is a time where having an ability, an app to really capture just the data of what you are doing, right? Even just like if you had a thing where every time you breastfed, you could easily capture it. Every time your child had a viral load that was negative, you could populate that in there. Every time, you're like, the situation like with your dad came up. I mean, that kind of situation is such a make or break for people, because many people are not fortunate enough to have that openness with their family members, right? And so if you don't have that, and the child's screaming and you're doing something else and you have no choice, then you can't risk it, right? So you just go with formula because of reality, and that's just not an option. So like, that alone shows how like maybe perhaps unnecessarily make or break those situations are. But even recording that, like, how many times was it like a matter of a sip or two of formula that almost had you change your entire feeding plan? Like, just knowing that would be really empowering, because I bet there's people out there who maybe don't take that strong of a stance. They're like, yeah, I exclusively breastfeed. I breastfeed 4 or 5 times a day. If there's a sip or two of some formula here or there, maybe they do that. And that's that, they're already doing it. We're not telling them to do it, but they could put that into the system too. And so we can get a picture of actually what we're really doing, and we could put it together, and it would have to be privacy preserving. It would have to be like anonymous, right? But it could probably give us the numbers we need for then anybody to go into their doctor's office and be like, see, 300 people last year put this in, or whatever that is, and they're still breastfeeding now, or whatever. I mean, 300 might be low compared to the real number, right? depending on how many people we can get to use something like that. It's just a thought, and it depends on whether that's along the lines of what everybody would want.
Well, I would have participated if that were available, if it were an option for me. Definitely. And I mean, it does seem like it would be just one more thing to do, but in the big scope of things, it's helping, not just me, but, women that are to come afterwards. Because I know that there are women before me who have breastfed who have not been able to say anything. So maybe they would have been one of the ones to report anonymously, but that information could have still helped someone like me today in 2022. So yes, I'm all here for that. When I was pregnant, I built a very close relationship with my OBGYN. Like he was the one he was the one that I saw the most. He was the one that we had the best relationship, and it was critical to my care and empowerment to choose how I wanted to feed my child. So what do you see as the role of OBGYNs in engaging parents in shared decision making as outlined in the perinatal guidelines?
It's great. It's a really one of the big tragedies of our field now is the lack of continuity of care. And the whole health system seems to me, it's like, okay, you're going to get all my gripes about the health system. One of them is that it seems as though the people who have influenced the design and the structure of our health systems have done it in such a manner that it treats patients and doctors and midwives and other practitioners as cogs in a machine rather than as people for whom the value of their engagement in this whole system is contingent upon that relationship and is derived from relationships itself as the source of value in medicine. And so it's great that you were able to have that. But even you said you saw other people too, right? And in the past that wasn't even right. That wasn't like normal.
Well, I had the whole team, Marielle. I had the OBGYN, infectious disease doctor, a high-risk nurse, a social worker, and I got linked up with the pediatrician before the child was even born so that we could talk about what I wanted to do when it came to feeding.
So I think that's, so in the system where that's not, that continuity is not going to come naturally. I think that my advice would be anyway, to seek it out. If you have to change an appointment date because your provider of choice is not available, that's more important than getting that appointment in before your 28 weeks or whatever. The dating is way less important than the person, having that same person. And so to the extent to which you can build that, the extent to which you can plan, if you're having a C-section, plan it for a day that, yes, you wanted to have it on 39 weeks even, but if you can have it 39 and 4 by the person who saw you all pregnancy, I would do that. The more you can do to advocate for and create for yourself that continuity, finding that pediatrician for your kid before you deliver, meeting them, having that continuity, the more you can do that for yourself, the better the services will be for you. Just automatically, without that person doing anything that they would have done differently, just based on knowing you and having that relationship and, putting the care in care, right? Like, just you care about the person, you know them, you don't have to spend 15 minutes reading their chart and looking at every number because you know it already. You can just go and focus on them. From the provider's perspective, that's huge. And it's what I think a lot of my colleagues are missing in the practice that we have today.
I loved it. I loved it. Quick story about my experience, and then we're going to jump into the comments. We're running out of time.
Yeah.
So towards the end of my pregnancy, my OBGYN, he was out of the office. So I was being seen by someone else who did not know me. So do you know they came in the room with an HIV test? I'm like 38 weeks pregnant and she wanted to do an HIV test on me. Like, wait, what? We're like going back so far. So just being able to follow through with one provider the whole time, I think that that does relieve a lot of stress on both ends, because I was halfway offended. Like, you didn't even take time to get to know who you were coming in here to see. But that's
Well,
it.
because you could easily look at the, knowing how these terrible electronic medical records are, you could easily look at it and see, oh, they didn't have a test this pregnancy. And that probably is where, again, they're trying to do their best they can with this crappy system that they've been handed. And they're trying to be thorough and make sure they don't miss something major. Well, you're like, well, if you had read one of the other 800,000 notes in my chart, you would have seen that, like, they didn't test me because it was unnecessary, because they were already following my, viral loads or whatever. It was just like, it's like so obvious. But, so I think on the side of, for patients, like, understanding that the provider that walks into that is like foot and mouth, feels terrible, and these records are just out of control. And I could easily see that mistake being made by somebody who's just trying to make sure something doesn't get missed. In reality, they're the one that missed it.
Mm-hmm.
But then, right, like, it's like, the electronic medical record is not a substitute for continuity of care. It tries to be, but it's not. Yeah.
Wow. Look, we are so close. This conversation could go on probably for like 3 days. We had so many great comments that were coming through as we were speaking. I know that Krista, she mentioned, do you think that until like we're able to get more research done in high resource settings, that there is an opportunity for policy change?
I mean, I think we're chipping away at it, right? Like, the guidelines have changed even in the time since I've been working on this. But I think that the change that's been in the guidelines so far has been insufficient to overcome all of the barriers created by a system in which, it's still bold and recommend, does not recommend, because that creates the distance and the disincentive to be forthright. But I think we need to keep moving forward. I think that this is where I'm going to be like, I think if we could just capture the data of what people like you are doing, like even the data that's been collected just from your own medical records, right? Like, you have access to those now. Can everyone who's doing this get access to their medical records, and can we compile them? Like, even that alone, like, even forget the app, right? Like, get your data. Let's get it together. Let's prove to people that this is happening and it's safe. And you sort of, even within the existing guidelines, there's room for that practice change if it's driven by evidence that we already have. And yeah, I think the policy is going to keep trudging along, but those policies take years to change. Like, Judy Levison was responsible for that policy, that last policy, perinatal HIV guidelines. Do you know how many years of meetings that was? I think we need change faster than we need policy. Then the policy even is capable of changing. And that's always how it is, right? The law has to catch up.
Oh my God, we're right at the top of the hour. So real quick, because I think this is very, very, very important. Lactation support. I know. So did you work with a lactation consultant if you were having trouble breastfeeding, or were you concerned that they would judge you? So when I got into the hospital, I had already had notes in my chart that I had the support of the pediatrician, OBGYN, and infectious disease, and they still tried to come and talk me out of it. I did not get lactation support until my 3rd day, right before discharge from the hospital, to help me get this baby to latch. But I did link up with a local doula service that provided me those services for after I came home. So yes, I felt like that was very important. If we talk about, not wanting to transmit and nipple health, and I had no clue about any of this, I definitely needed the support of those on the outside of me. Yes, but if you all have any more to say, please put questions, comments into the chat. We definitely really appreciate it, Marielle. I thank you so much. Before we get off, I want to remind everyone of the Well Project survey that's going on. It has not closed just yet. So, Marielle,
I gotta I gotta run, but
okay,
you're amazing.
bye.
And to be
Yes,
continued, please listen to
see
me
you.
as well,
This was
Jay.
amazing. Yes.
Bye,
All right,
guys.
bye. Um, So let's see if I can get this. Yes, the Well Project survey, which can be found at this bit.ly, the Well Project survey. Please take a moment to fill that out. Your responses are definitely well heard and well appreciated. We want to make sure that the programming that we have going on is meeting the needs of our community. So please, please, please just take a moment to fill that out. Today was wonderful. Thank you all. We are going to go ahead and end our second BEEEBAH session here. Thank you all so much. Goodbye.